Our next speaker was the Ogden Surgical Medical Society president in 2012. His partner, Adam Tainter, is the president-elect and will be our 2025 president. So please welcome to the stage David Allen.
Okay, well, it's a pleasure to be here, and I learned a lot about things I didn't know about asthma. I thought about the type 2 asthma and the non-type 2 asthma, and I wondered if I was a type 2 dermatologist or a non-type 2 dermatologist. I'm going to go with the non-type 2 for right now. But I do see we got a couple of my colleagues here, and I see Willard in the back there, so if I say anything that's wrong, just stand up and wave your arms, and we'll go from there. I'm excited to be able to speak here. This photo was from last Saturday night, and I would love to be able to take credit for that. This is from my wife. We live in a gorgeous area right here, and to be able to see stuff like that too. So in terms of an update in dermatology, I thought about all the things that I could talk about, and I've listed a few of those things here, but significant advances have taken place in everything that's on this list plus more just in the last few years. There have been, within the realm of melanoma, there's been some significant advances, and perhaps the best significant advances in treatment and therapeutics that are available. I'm not going to go into detail into that, but I do want to talk a little bit about some changes and updates in imaging, as well as prognostication and gene expression profiling. Typically, when we look at melanoma and someone walks through the door and we're looking to try to determine whether or not we're going to do a biopsy, historically we used some of these different types of checklists or of different algorithms to kind of help us make a baseline determination of what we do. And we still use this as kind of an algorithm to help people, to help the lay population to be able to determine whether or not they may need to come in and be seen. Many of you have seen this, the ABCDs of melanoma, an acronym for asymmetry, border regularity, color variations, diameter, and evolving. I want to just make a mention about color variations. Think of the color of the flag, red, white, and blue, plus the color black. Diameter is a much looser criteria. We see things that are huge that are not a problem, and we see things that are teeny tiny that are a problem. I don't love that criteria because sometimes it falsely reassures some patients that they don't need to come in because it's only 3 millimeters, but we see 3 millimeter melanoma, invasive melanoma even. Most important thing is probably the evolving over time. This is just a slide I wanted to show that's kind of important because here we're seeing that the incidence of melanoma is increasing, and it's been steadily doing so since about the 1930s, actually. But one of the things that probably is at play here is there may be an overdiagnosis of melanoma in terms of pathologists being a little bit gun shy to call things that may have 20 or 30 years not been called melanoma, maybe to be called melanoma today. Nevertheless, the incidence of true melanoma is actually increasing as well. But what I want to focus on is right here on the far right end of the graph in the red where it says mortality. You'll notice that it kind of was ticking up a little bit, kind of mostly flat. It's still mostly flat, but if you can just see at the very end around 2015, we all of a sudden start getting a little tiny bit of a trickle downward. I was sitting by Craig Foley, and he says pretty much if you had bad melanoma, it was lights out and that's it, and you get your effects in order. However, things have changed to a point where that's not necessarily always the case. As far as imaging, there's a lot of different ways that we can image, and most dermatologists are now using dermoscopy, which is a handheld way to visualize the skin. We can see about a millimeter into the skin. It's really cost effective. It's not very costly to be able to obtain one. However, there's a pretty significant learning curve in being able to do it. Reflectance confocal microscopy is more expensive. It can go deeper in the skin and can provide some great images. Optical coherence tomography is something that's newer, but it's expensive and not necessarily ready for the bedside, as is high-resolution ultrasound, which can penetrate deeper. These are 6 different modalities. We're going to talk about the top 4 up here. And these have different abilities to penetrate different depths of the skin, but the resolution that you can get and the information that you can get from some of these modalities is actually quite spectacular. In reflectance confocal microscopy, it's a typical microscope, except for the light source is a laser light source, and it's pointed right on the skin, and you're able to obtain an image that you can identify. The problem is that in a high volume practice, it's hard to wheel this thing from room to room, and if you got a bunch of dermatologists in the same areas, it's not really practical to be able to use it. And considering that these machines, a used one might run $45,000, $50,000, and a brand new one runs up into $150,000 to $200,000 range, and there's no actual compensation for it just yet. Although Medicare in 2018 did actually create a way for dermatologists to be compensated for it, a lot of insurers are not necessarily following that. But it's bulky, and it's a little bit difficult to be able, and you have to find that exact image. And so a lot of dermatologists is, if I'm going to take all that effort and be able to put that on there, it's quicker, cheaper, safer to just do a biopsy and do the gold standard. Nevertheless, it can provide some spectacular images, and you're able to look almost like a CT scan as you go down through the depths and the layers of the skin. You can get quite good resolution of what you're looking at. Here we're looking at keratinocytes, just showing you some of the resolution that we can get with reflectance confocal microscopy. We talked a little bit about the CPT and reimbursement, and that basically the cost is similar to that of doing pathology plus the biopsy as well. And so right now it's more cost effective to just go ahead and do a biopsy. The downside is scarring, and so in certain areas of the body, perhaps the face, where it's more cosmetically intricate, we might not necessarily do that, and LCT can be good. Optical coherence tomography is something that's not quite ready for bedside yet. It actually employs a couple of different modalities, but it basically generates the same kind of thing. There's a little ultrasound along with a light source. It's an almost coherent light source. It's not a laser source. It's kind of a bright visual light, and you're able to run different frequencies and be able to see different things. The image in the middle here is showing a basal cell. These are all basal cell carcinomas, the same basal cell carcinoma. In the middle, you can see some shadowing where you're able to see where that carcinoma is. On the left, you see a dark kind of band. That represents some of the clefting that occurs within these basal cell carcinomas. One of the limitations with any kind of imaging like this is the ability to be able to see melanocytic lesions, because they don't tend to work very well, particularly with reflectance confocal microscopy. However, with OCT, we're able to get a little bit of a visualization, and you can actually start seeing melanoma. And so there is in the skin, which is the first visualization of the skin into the skin, where we can actually see some of these changes of melanoma. Melanoma becomes very, very difficult to see and to recognize sometimes under a microscope, let alone with a visualization via some sort of a scan. High-resolution ultrasound is actually amazing. The technology that's gone around, many of you probably use this at bedside for diagnostic purposes in primary care. I know ortho uses it quite a bit. I don't know about rheumatology, although I think that they probably do as well. But it's able to generate a high-resolution image. Again, at the very bottom of this, there's a lot of different applications that this would have, that this has in dermatology, beyond just being able to pick up and diagnose cancer, but lots of other things too. But melanocytic lesions are still extremely difficult to visualize using high-frequency ultrasound. Here, this is just showing your typical layers of the skin, where we got the epidermis up high, the dermis, followed by the subcutaneous. We got the superficial fascia, the deeper fascia, and then able to visualize down in the muscle, which is really helpful for being able to visualize neoplasms that are under the skin, and we're not sure if they're a fibroma or if they're maybe a potential sarcoma, that you might be able to get a different echogenicity pattern. So high-resolution HRT can actually really, or ultrasound can really help be able to visualize deep. Here's an example of a nail fold, and you can see the proximal nail fold, dorsal plate, ventral plate, nail bed, and be able to really visualize that entire area, which can be quite helpful. The problem, again, is that these are machines that are fairly expensive, and being able to have them in a high-volume practice and move them from room to room, or be able to store them, stay up with the technology with them. Plus, the learning curve that's available with them has made most dermatologists not necessarily utilize them. However, you can see that they can help define borders, especially when you're doing maybe a surgical excision or Mohs excision. You're looking to see what your borders of a particular tumor may be. This is able to help us identify some of those things. Dermoscopy takes a different approach, and it's just basically visualizing it. And with polarization, we're able to actually see a little bit deeper into the surface of the skin, and the estimates are that we can get down to about 1 millimeter, maybe 1.5 millimeters, to be able to see some of those structures that reflect back up into the skin. This is a much more practical device, as it's a handheld device. It's got different types of light. They're still relatively, they're not $100,000. They're a handheld unit. I think Adams are close to $100,000. He likes the high-end versions of them, but you can use them to be able to visualize things. So here's an example of 4 different lesions, and we've got pigmented basal cell carcinomas, we got melanomas here, but you can see that you can start picking up patterns as you're able to visualize underneath the surface of the skin. There's been a variety of criteria that have been used in looking at dermatoscopic images, and there's a variety of different ones, and this happens to be the ABCD one for there, and then there's a score that you get, and you're able to put all these things together and then to determine a score. There's different checkpoints that you can use when we're looking at the ABCDs of melanoma. This is not something that we're going to go over in depth, because you're not going to become a dermatoscopic expert in this in the next 15 minutes in this talk. But really, look at E. So E is, noticed a change in the last 3 months. That has nothing to do with the image. That has everything to do with what your clinical gestalt is when you see the image as well. So you're taking everything together, including what you're seeing without the visualization. There's a 7-point rule where there's certain different types of dermatoscopic findings that are listed here in bold. And you get certain numbers of points, and if you get a score of, I think, 3 on this one, that you end up having melanoma. But anyway, if you look at this is interesting. This is a study that was done looking to see the sensitivity, specificity of just visual inspection alone now this is actually done not by dermatologists. This was after non-dermatologists had been trained to see skin, and then they were trained in some of these algorithms using dermoscopy. And what their change in ability was to be able to determine and pick up melanocytic lesions and melanoma. And they found out that visual inspection alone, we had a sensitivity specificity right around 75. And yet when you combined dermoscopy after they'd been trained, that pushed specificity up to 95 and sensitivity up to about 92%. And which is way superior to clinical inspection alone. So this is called the cache algorithm here, and you get different scores with different types of things. And so we're looking at asymmetry, we're looking at globules, we've got all kinds of other different terminology that we use, blue-white veils and comma-like vessels and different things that we see. I put this slide on here. These are benign lesions here. But I put this on here because we use dermoscopy as well, and this is really helpful. In kids, a lot of you pediatricians or family practitioners, maybe you and your grandchildren, you find kids that have these moles on their scalp that can sometimes be fairly large, and they're often very dark, and they're centrally pigmented, so they've got multiple colors, and they're big, and is this melanoma? And that's always the question. Jean Bologna, who was chair at Yale University for a while and now is program director, I actually think she just stepped down, but she coined the term eclipse nevi. This is an eclipse nevus, where it's like the sun sitting in front and you see the corona around it. But dermoscopy, we can see these. These are predictably benign, and we tend to not take these off. Adam, do you take them off? I don't take them off. Okay. Here's an example of a clinical image of something that's suspected to be a melanoma and is marked there. And here you see it dermoscopically, and you've got some asymmetries, some irregular patterns to it. This ended up being a melanoma. Here's another one. Someone comes in with a new dark spot on their finger, on the volar surface of their finger, and so you wonder, well, what is this? Could this be melanocytic? There's some hints here that it's not melanocytic, namely the dermatoglyphic going through that line going through it suggests that it's probably in the stratum corneum and not actually in the epidermis or in the dermis. Dermoscopically, we can see that this is indeed a subungual or a subcorneal hematoma, basically a blood blister. Here is something that Adam and Willard had recognized immediately as a dermatofibroma, but there's certain patterns. The starburst pattern in the middle here is a predictably benign lesion of a dermatofibroma. When we're looking at acral lesions, we want to know whether or not the pigment is on the top or on the ridge, or if it's in the furrow. This is in the furrow. The ridges are more broad, so this is a benign acral nevus here. And again, we're looking at all these different things: scar-like depigmentation, pepper granules, parallel ridge patterns, and all of these different things here are basal cell carcinomas on the upper right, and then melanomas down below and on the left. These are descriptions of different types of networks. The benign lesions are up top, and then the one on the upper left is melanoma, and the central one on the top is a benign nevus. The rest are all melanoma. And here we've got a bunch of benign lesions with pseudo findings that can help us be able to differentiate melanoma from non-melanoma lesions. It's particularly helpful when you get someone that comes in like this. These are four different people, four different diagnoses, and all of them interesting, okay? So let's just take a vote of hands. There's two of these are cancers and two of these are not, okay? So upper left-hand corner, who votes for that being cancer? Everybody raise your hand. You got a 50-50 shot. It's yes or no. Okay, so no one's going to take a step there. I would have a hard time knowing. I put a dermatoscope on it. I'm like, okay, this is vascular. This is okay. This ended up being a pyogenic granuloma on the upper left. How about the upper right? Cancer, yes or no? Now you got 2/3 of a chance of getting it right because there's only 3 left, right? So the upper right is not cancer. That's a cherry angioma, okay? The bottom left happens to be a Merkel cell carcinoma, okay? And the bottom right is an amelanotic melanoma, okay? But you can see where being able to do a bedside thing, because I might do a biopsy on a pyogenic granuloma much differently than I'm going to do a Merkel cell or a melanoma, where depth becomes extremely important. Okay, we're going to shift gears here a little bit and try to, in the next few minutes, talk a little bit about some detection and determination about the aggressiveness of a particular melanoma based on some genetic gene expression profiling. I want to put this up here too, because again, we're looking at the incidence of melanoma rate per 100,000 per year, and we went up until about that 2010, 2012, 11 mark, when all of a sudden it starts coming down, okay, where they're actually we're making a difference somewhere. This was this is the incidence rate. The other was the death rate. So here we go, talking about expression profiling. So in gene expression profiling, what we're really doing is we're looking at the gene product that's there. And so you get a tumor, you have to have at least 50%. You get the tumor that's on a slide, and you can do it on paraffin-embedded tissue. You isolate the RNA, you get out cDNA, you amplify it through a variety of techniques. Then you end up having, you're able to see the products of different genes that it follows. And then you take that, you put it through an algorithm, and you come up with different classes, okay? And there's a variety of different companies that are doing this. One is Castle, who's kind of pioneered most of it. But the Mayo Clinic has an algorithm coming through. Yale has an algorithm coming through. Michigan has one coming through, University of Michigan. And it's created a little bit of a challenge because the Michigan guys don't like what the Castle guys are doing, and the Yale guys don't like what the Michigan guys are doing. And so we haven't come to a consensus yet. But this has actually been validated through a number of different studies. And these slides are courtesy of a friend of ours, John Vetto, who's at Oregon Health Sciences University. So this shows you the products that you then see. So you've got all these different gene products here, okay? So what do they mean if you've got these gene products? Well, the amount of gene product, the percent of them, makes a difference in terms of determining what it is. So when we look at this, we can stratify recurrence risk in sentinel lymph node negative patients, okay? So these are patients who had a higher risk tumor because it was a certain Breslov's thickness or it was ulcerated and it requires sentinel lymph node biopsy. Sentinel lymph node biopsy is obtained and they're negative, but a significant number of those, a number of those will eventually develop metastatic disease or at least nodal regional disease later on. And so how do you account for that and be able to get rid of that? Well, when you use this type of a thing, you're able to take the melanoma staging and you look up at the wide local excision and you're deciding whether or not you can do you either do or don't do a sentinel lymph node. And then if you do this genetic test, this GEP testing, and you find out before you do the GEP testing, you've got the AJCC guidelines, right? And they're changing all the time and trying to keep up with the time. Most recently, it changed in about 2021 and for melanoma. And you stratify them into stage 1, 1A, and then the different stages. Well, if you add then the GEP expression profiling, you're able to classify them whether they're a low risk for recurrence, low risk for metastatic disease, or a higher risk. So you might take someone that's a low risk and maybe had a negative node, but is a high risk class 2 based on the gene expression profiling. Those are the ones that tend to recur. Then what we're going to do is we're going to do serial imaging maybe of nodal basins. We're going to maybe bring them back into clinic and look at them a little bit closer. Or maybe we're going to do PET scans, serial PET scans over the course of the next several years. And if they're higher risk and they have this and they have and they're not quite stage 3 or they don't quite meet all the requirements to be able to receive pembrolizumab or some of the other adjuvant therapies, they might actually start on adjuvant therapy earlier and have an improved overall outcome. So here, the GEP score is just showing that the data is starting to show for years and years and years. Let me back up. For years and years and years, it has always been widely known that Breslow's thickness, in other words, the depth of melanoma at the time of diagnosis, has been the absolute most important indicator of and prognostic indicator about the severity of a disease. And we've been, in all of our staging has basically been based on that until we get to a positive sentinel lymph node in which we're stage 3, and then metastatic disease, which would be stage 4. But even more important than Breslow's thickness is the GEP score. Mitotic rate used to be actually quite important. That got knocked out of the AJCC 2021 guidelines as well. And then age had become less important over time too. So GEP becomes really highly predictive in terms of how people are going to do. So we tend to order it in tumors that are greater than 0.3 millimeters. And then we stratify them into these different classes, and it shows you what the risk of recurrence-free survival and then disease-specific melanoma-free survival as well over time. And you notice that even with the same T stage, you can have different outcomes based on their GEP expression profiling stage. This is just showing that in clinicians that have adopted this and have been using this, that the vast majority of time, about 2/3 of the time or 3/4 of the time, it does make a difference. Either they're going to do less, in other words, someone that's maybe a little bit older that would normally get a sentinel lymph node biopsy, we might have a discussion with them because their gene expression profiling is a class 1A. We say, look, this is low risk. You're probably not going to do it. You're 83 years old, you've got all these other comorbidities, or 85, and we're recommending not doing a sentinel lymph node. Or you might have somebody that's got a 0.4 millimeter, they've got a class 2A disease, and we might say, let's go ahead and do a sentinel lymph node biopsy with the wide local excision, or at least we'll do serial ultrasounds or serial scans to change it. We might even do more LDH studies and such just to monitor for potential distant disease. So in this, this basically just shows, it was a study that was done, and it basically just showed that the survival was, with GEP, actually improved once those guidelines were followed. Now, this is interesting. This is an aside, a kind of parenthetical phrase, if you will. Statins is associated with overall survival in patients with melanoma, and so maybe putting some of these higher class GEP stages on a statin may decrease it. And so here you can see the 5-year survival after diagnosis of melanoma. The N is okay. This is a cohort of about 100,000 people monitored over 10 years to look and see how they would do over time. Here you're able to see on the left, on the bottom, second from the bottom, you'll see that the statins had a significant hazard ratio decrease of 0.38 which was the best of anything. Beta blockers are showing some promise in that, and the combination may actually be more beneficial, and that's currently being studied. So why would that happen? Well, when you look at the gene expression profiling and you take statins and you put somebody on statin, you follow them, and then you do the GEP, you find that statins can actually alter and shift and change gene expression profiling, and may make a difference long-term in the outcome of certain forms of melanoma. We're going to skip this slide here. And so here we're looking at some of the most significant independent predictors of outcomes compared to some of the features that you might see clinically with it. And you'll notice that right at the very top of that list up there is whether or not you've got, for melanoma-specific survival, that you've got the class 1A, 1B. And if you look at the second one down, the hazard ratio is 7.0. We're talking a positive hazard ratio here, or a negative hazard ratio of what's going to happen with when they're with their overall survival with melanoma if they have a class 2B. And likewise on the right, the overall survival is shown the similar manner. So what about imaging? Here there's a paper in the archives that shows that people who had the higher stage 31 GEP assay, that they were being staged and they were being serially followed over time, and that they had overall decreased metastatic tumor burden without following the routine guidelines. This just is kind of a timeline of the adjuvant therapy and FDA approvals. And forever we had interferon alpha, and so you'd get metastatic melanoma or stage 3 melanoma, and then what we do is we'd give you interferon alpha, we'd make you feel like you had the flu for a year, and then we would take you off of it, and then they wouldn't do very well, and they'd pass away. And so it was always hard to know whether or not to do that. When we got pegylated interferon alpha, it was a little bit better. Ipilimumab came along, nivolumab, and now we're on pembrolizumab on the end. These checkpoint inhibitors have been absolutely amazing game changers for certain forms of melanoma, and are really encouraging. And the breadth with what is happening is also amazing. A couple other things that are not on this list is TVEC, which was using herpes virus antigen to be able to promote remission in some forms of melanoma as well. This just shows that using all of those pembrolizumab in all of these node-negative melanomas, but that are high risk with that class 2, that it improves survival in each one of those. So basically, in the last 10 years in dermatology, there have been amazing strides that have been made in a lot of aspects of it. There's a rapid evolution in disease and diagnosis management. It's had a significant impact on both the morbidity as well as the mortality, and improved overall survival and quality of life of all of our dermatology patients. And I think the future is super bright, especially as we start combining AI technology with some of these imaging modalities, as well as some of this gene expression profiling. I think we're gonna find melanoma eventually become a disease that is somewhat like some forms of breast cancer, where it becomes more just managed and maybe even cured as the evolutionary process continues. With that, I'll take any questions if there are any. I must have done a really good job explaining everything. Fantastic. Okay, thank you for your patience.
Dave, I'm sorry, one quick question.
Yeah.
I had a patient just last week who has melanoma, metastatic inner lung, but they couldn't find the primary. I'm just curious, how often does that happen?
Yeah. So that unfortunately, well, okay. So a couple things. Having melanoma with unknown primary is something that occurs. The occurrence rate of that is fairly low. It's about 0.5% of all melanomas. It's still fairly high, but we do see it, and typically it's lymph node only disease, and not metastatic to other organs, although that happens sometimes too. And remember that you have melanocytes all throughout your throughout your GI tract, and it concentrates in the rectal mucosa. You've got in the ocular retinal pigmented epithelium, and you also have it within the brain and the choroid plexus and in the meninges. You got melanocytes as well, and so oftentimes there was an occult melanoma there, wasn't detected, and when you look on scans, one of the things that we know about for sure is that melanoma can regress, and that happens in the CNS as well. And so oftentimes there was one of those primary, and it could have happened in the skin where she had a regressed melanoma, wasn't diagnosed as well, and you can get that type of disease as well.
Hey, Dave, quick question.
Yeah.
Dermoscopy intrigues me. Is that something that's being taught in primary care, in family practice residencies? Is it something I should be able to learn?
It's not being taught in primary care as far as I know. There are some places where it is. There are some really good online resources with learning it. It is good to be able to do it. There is a little bit of a learning curve with it, but it can be very, very helpful. Adam, you were going to say something. So Mark Noob, so Mark Noob is a dermatologist, friend of ours and colleague of ours, who kind of has pioneered a lot of this stuff in it, and he does do a lot for primary care. And there are some online, he actually has an online course for primary care that I think is free that you can take as well, and it can be very helpful.
Okay, thanks.
Yeah.
About some of the medications that you use. You hear on the TV every day, half a dozen times, ask your doctor about this medication. I just wondered if any of those that you use out here are some of those that they say ask your doctor about.
If any of the ones we talked about are the ones they're talking about, ask your doctor about. None of these have I seen. I've seen Keytruda, I think, I don't watch a lot of TV, and so I don't know what's on there, but some of the other things I get on the internet and stuff when I'm on, we'll talk a little bit about Keytruda and some of the checkpoint inhibitors and ask your doctor if that's appropriate for you. So some of those, yes. A lot more of the things that you see that ask your doctor about have to do with the IL-13 and the IL-17 and the IL-5 and the all the IMABs that we've got out there, and some of the JAK inhibitors as well.
Thank you.
Are you guys leveraging any of the AI software, Skin.io, et cetera, into your clinic yet?
So we're not in our own. There are some AI products that are out there, and there are some apps that are out there as well. Universally, when looking at studies on those, the studies have not panned out as being accurate or being able to be reproducible and being able to be very something that we can actually be confident that we're getting what we want out of them. So I think that that's down the road. We're not employing them yet just because we don't trust them. Anything else? Okay.